Okay, everyone. And Josh, I see that our room is emptied a bit, but I have a feeling they're all going to start coming in when they hear you. Everyone, if I could please introduce Josh Nemaire. He taught me how to say his surname. I'm not sure if I got it right. And Josh, I'm going to ask you to tell us just a little bit about yourself, and then we can't wait to hear you play.
Thank you so much, Joshua. That was great. And that takes us into our final session of the day before we break for lunch. And this session is on digital health innovation for adolescent healthcare. And it's my pleasure to introduce the chair of that session. Associate Professor Elona Toska is an adolescent health researcher at the Center for Social Science Research at the University of Cape Town. She's the director of the Adolescent Accelerators Research Hub, a unit within the center. She co-leads several studies, including the Mzansi Wako Adolescent Health Study, Hey Baby, Adolescent Mothers and Their Children, the Uplift Data Linkage Study, Screen and Support Package, and HIV prevention among adolescents and young people in sub-Saharan Africa. Thank you so much, Elona.
Hi, everybody. It's great to be here, and I'm looking forward to learning a lot because I do feel that we have to keep up with all the innovation in digital health. It's my pleasure to introduce two speakers, Dr. Ntombifikile Mtshali and Dr. Homaira Hanif. So I'll first introduce the first speaker, who I hope is nearly ready. It's my pleasure to have Dr. Ntombifikile Mtshali, who is the Chief Executive Officer of Shout It Now, a South African NGO that delivers youth-friendly, community-based HIV prevention, sexual and reproductive health, and related services in Gauteng and Northwest. Dr. Mtshali is an experienced manager with an exemplary 12 years postgraduate track record in clinical work and health service management, blending her experience in business reengineering seamlessly with her technical expertise and extensive public health management experience. I'm really looking forward to your talk and to meeting you.
Good afternoon. I know I'm standing between you and lunch today, but what lovely music do we have this afternoon? Good afternoon once again. Pleasure for me to be here, an honor actually. Thank you so much to talk about the digital. Okay, pleasure for me to be talking about the benefits of digital tools in promoting adolescent health. Let's try this. I represent Shout It Now, as Prof. Elona has already spoken about it. We are a youth-focused South African local NGO with the aim of empowering youth to make the best choices for their own health and well-being. So lovely to have to hear some of the conversations around how we normalize conversations for young people, designing tools, designing systems and processes and services that are geared for young people. 3 pillars of our model includes making sure that we provide convenient health services, also creating demand for our services for youth in spaces that they feel safe, where they feel heard, and that are engaging for them. So our focus is on sexual and reproductive health and rights. So SRHR. So just to, I see there's a guitar that's still blocking my my slide. Thank you. But the important part here, and this is why it's exciting for us to be here, is about how technology is used as the backbone to be able to power our model. You'll see we're not a tech-focused organization, but we use and we leverage tech and digital tools to be able to reach our population. Now, adolescence, we know it's an interesting time. From a biology, mind, psychology point of view, our body's going through a lot of changes, identity development taking place with all the changes that can be overwhelming to deal with. I want to start by asking somebody was asking something about teenagers. I don't know if we remember at that time. Some of us might need us to recall quite a long time ago. But adolescence is a time where a lot of changes are happening. There's a barrage of emotions, hormone surges, excitement, new feelings that are happening. Most of us struggled. We did not have people to talk to. You were lucky if you had people you could talk to. Many youth struggle with shame, with guilt, judgment, isolation, sexual abuse. From what we know also, young people get into sex, start having sex, not because they want to have sex necessarily. Some of those relationships are quite coercive sexual encounters. So now include that or put on top of that, you go to a facility, you get judged, you are not feeling safe to be able to ask the questions that you need to ask. You do not feel you can access the services that you need to be able to be mentally and physically healthy. So I'm here today to promote the use of digital health tools for youth because they can provide a valuable bridge to health and wellness services during a turbulent time of life. I want to also quicken to say this, that digital tools on their own are not the silver bullets. They need to be linked up with they work best as a component of a youth-friendly, comprehensive in-person healthcare service. So in the context of adolescent health, digital tools that are relevant, accessible, and accessible can be powerful ways for us to be able to engage and support the youth, particularly youth that are not being necessarily reached easily, so in hard to reach places, but also making sure that, bridging that gap to be able to have health equity. That being said, it would be remiss if I didn't mention the potential downside. And I know a lot of us think about the bad side of technology, et cetera, but I wouldn't, the potential downsides of young people accessing digital tools. We know there are some risks. And I'm, as a mother who has an adolescent child, and a preteen, I already know that youth are already spending an unhealthy amount of time on their cell phones and devices. There is risk. Could you hear me okay earlier? I feel like now I'm extra loud. Is it better or is it? Okay, better. Okay, so we know that there's risk of privacy and confidentiality breaches if you do not set up the controls. I was last weekend, I was trying to figure out with my son who's 10 on how to put parental controls. I had to ask him to help me. Yeah, no, I knew I wasn't on the right path, but we eventually did figure it out. The risk of exploitation, lack of parental consent because he was downloading roadblocks and stuff like that. And I'm like, who allowed you to do this? And it's an interesting one. But also the quality and the veracity of information. We know this, especially with COVID-19, we all became experts in COVID-19. We knew what to do. And we couldn't filter and create information that is important. The idea is to try and find, as we move forward with this conversation, how do we make sure that the concerns and the benefits outweigh? So certainly in our view, we feel that benefits of these tools far outweigh the potential risk, especially if we put this necessary measures in place, the guardrails, to be able to mitigate the risks. So the risks, and I think the benefits you can see from that side, it's when we've got, because of such a critical time, we don't know for young people to be able to get information that is credible. But also there's a stigma. The last speaker was talking about it to a certain extent, a stigma around why do you want this information? So this allows them to have discreet and convenient access to quality health information and linkages to care. We also see tools and resources to help youth adopt healthy behaviors and seek supportive health services, digital social interaction opportunities to provide and receive peer information, share experiences, etc., etc. In many ways, our debate today about whether youth should have access to digital health tools is a little moot because the horse has already bolted. It's no longer around if youth should have access to these digital health tools. It's about how we make it access, how we provide them with the best tools for their health needs. As you know, digital health services are on the rise due to the increase in the number of smartphones and internet service access, with 76% of South African mobile connections projected to be via smartphones by 2025. Our chairperson of the session, I'm going to quote her on a great report that on mHealth Access that her colleagues that her colleagues at UCT did, that in 2014, UNICEF reported 34% of South Africans aged 8 to 13 and 69% aged 14 to 18 had access to mobile phones. So, and we even had higher rates of self-reported mobile use in the past, in that particular month in 2019. COVID-19 also has accelerated the development of remote access solutions and technology to provide services. We know this via in terms of vaccine mobilization, contact tracing, as well as disease tracking. That became very important. So it accelerated us not just in the developing world, but globally, and it prompted a shift in the way that we provide healthcare and how it is being delivered. A shortage in our context as well, a shortage of trained nurses, doctors in the areas that we need, particularly in rural areas, highly populated and lowly resourced urban and peri-urban areas. For context, I just want to do a quick review because sometimes some of us also get confused in terms of what we mean by these terms. So I want to do a quick review in terms of the differences of the most common digital tools that are being used in the health space. Let's start with social media. I know it's not a digital tool, and I'll cover that in the next slide. But social media is a digital technology that allows the sharing of information and ideas, including text and visuals through virtual networks and communities. So Instagram, think Instagram, Twitter, Facebook, etc., etc. And TikTok, how can I forget TikTok? Digital health is an umbrella term that we use for the use of communication technology in healthcare settings. Telemedicine is a provision of remote or virtual clinical care consultation with a medical professional. mHealth, which is a general term for the use of mobile phones, devices, and other wireless technology in the healthcare setting. So think Mom Connect and the likes, especially in the antenatal space. Artificial intelligence, which has become a very interesting one. Everybody knows AI, and I know some of us know ChatGPT particularly, which is a subset of that. But artificial intelligence is the ability of a digital computer or a computer-powered robot to perform tasks that are commonly associated with intelligent persons or beings. We assume that, right? So like I've said, using social media, although it's not technically a digital health tool, I think it's important for us to consider its undeniable hold on the youth and how it can be used to then help advance adolescent health, because as I've indicated, the youth and young people are glued and they're addicted to social media. So the best way is how do we make sure we put the information that is accessible for them in the way that they want to access it, in a way that also allows them to understand it. So in the recent most recent social media landscape report, Facebook, TikTok, Instagram, WhatsApp, they were the most popular popular platforms for youth between the ages of 15, 22 to 24. So we know about the potential harms of social media amongst young people, which include, they are developing brains, so they're susceptible to, issues around self-worth, comparing it to each other, et cetera, and also the traumatic phenomenon of cyberbullying and the exposure to youth to online exploitation and abuse. While these harms exist, on the right side, you can see that we've got some benefits, and some studies have already shown how this can be used effectively around mental health, particularly, as well as adolescent health. So we can already see that there's proof that we can be able to improve health outcomes, and those are just some peer-reviewed articles around that. So at Charles, we just want to highlight in terms of how we've used digital health tools to be able to reach our population. So we've been drawing from literature on effective approaches to youth engagement around SRHR to design social media campaigns that both educate and drive health-seeking behaviors. Our More Girl, Get Your Life Pack, which was a 8-week multimedia campaign, which was targeting particularly females aged 20 to 24-year-olds. I think we've got some converted people here in the room. We know they are an elusive group to find. But that campaign, it resulted in a 53% increase in HIV testing, which I think is positive. And also it resulted in a 49% increase in PrEP initiation amongst those particular population group, which was a plus for us. Leveraging on the motivational series, using the role model framework, the social media campaign, this one, I forget to use my laser pointer, apologies. The role models framework, this social media campaign featured successful female South African leaders who were in various fields of their work, providing motivational messages around to young women about overcoming abuse, financial difficulties, cultural challenges, and health issues. And then most importantly, we made sure that they can be linked to the services should they need so for additional support through our mobiles and other online platforms. Our PrEP campaign, which was capitalizing on youth preferences of anonymous SMS dialogues. The social media and messaging campaign drove awareness and understanding of PrEP amongst a broad audience, and especially encourage PrEP initiation and retention amongst the group of females, 20 to 24-year-olds. So what we did here was to leverage cultural and social trends. The campaign was crafted to normalize conversation around sexual health and the services that are available to effectively prevent HIV. I stress this issue around making sure that we're raising awareness, but also making sure we can link the youth to the services. And that has been an important pillar of our work and the success, that we don't just give information, but we also give an understanding of where you need to go, how you need to reach out, and how you make you make a booking in those particular population groups. Edutainment, this was one of the things that have gotten us a lot of traction in the youth engagement from the Word on the Street drama series, which utilizing edutainment to raise awareness of the benefits of PrEP and directly link interested youth to further dialogues with the call center representatives. So we've got what we call a Connect Hub, which is our call center that allows us to be able to make bookings, and also they can go on our online platforms, make their bookings with our mobiles and the community-based services. Anecdotally, we know that our social media campaigns have increased awareness of SRH services and have educated the youth. While awareness and education are helpful and more impactful. I've already spoken about this, is about linking the service. I sometimes talking ahead of my slide, I apologize. But the direct service uptake, and we can be able to attribute this in a coherent way to the campaigns. So the stats that I've shown here are on clients requesting health services via the Facebook, Instagram, and WhatsApp accounts, and you can already see that significant proportion of we reach about 3,112 clients that have engaged with the Connect Hub, which is our call center, and requested service booking. Of those clients, 42% actually came. So they came to their appointments and they booked and they took up services, which is what is important. So out of that 1,311, 644 were our target population, which is the 20 to 24-year-old females. And so 644 of them took up the services, 456 of them were initiated on PrEP, and 219 or 219. I'm Zulu, ne? Please just forgive me. Numbers sometimes confuse me. So females access contraceptives were 219. So which was a positive for us. And obviously there's some lessons that we've learned from this exercise in terms of how do we do it, how do we make sure we do it better, and how do we also measure it in a way that is systematic. Now, in terms of the digital tools operating just in the South African environment, so there are 2 digital health assessments that were conducted in 2021, one by the Vital Wave and another by Map and Match under the Digital Square. Together, they identified a total of 150 digital health systems, apps, and tools in South Africa. I want to draw your attention that so some were education and awareness, and some were virtual engagement, communication, and platforms. And I want to draw you in terms of this nexus in the middle here, where you then see our iShout as well as our Chomi, which I will speak about in terms of those shout-built digital tools that come in the middle. And our iShout is the data-free app that we use for adolescent girls and young women. It allows the clients to self-navigate, because that's what's also important. They need to know, they need to drive their needs, and they need to be able to say, what is it that I want, not to like prescriptive. So we try not to be prescriptive. So I allow them to self-navigate through HIV prevention and related information. They are able to locate shout services in your communities. They're able to book health services. They're able to receive reminders for appointments, and also to just remind them about medication adherence, manage their rewards for the healthy behavior. So we've got almost something which is almost similar to the Vitality. So X number of points, if you come back for your appointments, you come back for your test, et cetera, you get allocated an X number of points. And then they can also redeem these from the Eyakoma Girl Marketplace. And then our Chomi app, which is our GBV chatbot. It's WhatsApp-based, it's multilingual. We've got it in 4 South African languages, English, isiZulu, Tswana, as well as, I want to say Afrikaans, but I don't think it's Afrikaans. It's running away from me, but it's Xhosa. So it's designed to address the fundamental barriers. We know that there's a lot of barriers that survivors face after being abused, or it includes fear, it includes the lack of a perceived lack of options, misplaced guilt, shame, and blame. So our Chomi app, we call it Chomi, which means my friend. Then they're able to self-navigate as well. It contains over 640 unique messages across 9 different content streams, and provides connection to support services as well via our shout social workers, but also we've connected them in the nationally. So that's also another thing, that we don't want just the Chomi app to exist in the geographies that we've got, but because we want to be able to link with the services exist, we have to do that mapping of what are the services that are available and how do we systematically link young people or people to those particular services. So the hotlines, Tutuzela centers or crisis centers, as it were, that's an important pillar as well. In terms of the digital tools, just trying to, oh, this is supposed to play. So it's just at the end. Thank you. I think this is just the Chomi demonstration as well. Thank you. So our digital tools, the impact so far, we've got on our iShout app, we've got 4,000 active users. We are encouraged, and obviously we've got a feedback mechanism for us to be able to monitor what content we need to be pushing to, when, you know, what is topical, what is it that the young people want to know about. We receive about 20 questions from adolescent girls and young women. This is not everybody that's there, but on average requesting different services, and that allows us also to tailor our content in terms of what it is that we need to be communicating at that particular time. What's also encouraging is that close to 600 users have requested services, and this feature was launched in August 2022. And then in terms of Chomi, we've got 1,639 unique users. 39% have requested social worker support, which is encouraging, and 3,500 content streams also have been accessed. Just on the terms of the social worker support, what we do when our clients come onto our mobiles, we screen them. We also ask them questions around GBV, whether they've been abused in any way. Most of the time they'll tell you no. And we actually give them an opportunity to, we tell them about Chomi. And when they go to Chomi, they find that that is a space that they can actually then request. So when they come back, so then when they request on the app or on the chatbot, we are able to then link them up. So it's quite interesting that they will not voluntarily disclose at the outset, but when they've been given more information in the platform. So this definitely talks about the impact that this particular platform has. Just in closing, and I asked how much time I had, and they were not sure. So it means I can actually talk for the whole afternoon. No, we finished, but my slides are not moving. So maybe that's a sign, right? Can you assist us with just moving it to the last slide? It's just to talk about artificial intelligence tools, because this is a developing field, and there are promising uses of these technologies that have particularly potential application for youth, including information that can help programs improve HIV prevention and treatment services by predicting clients' behaviors. Already NDOH, I think we might know, I was actually sharing with Stephen that even Palindrome, a group at Cape Town, well, yeah, in Cape Town, helped, designing a predicting model to see which patients are likely to fail or show up for their treatment, et cetera, and then that allows the programming to be designed in a way that targets the ones that are who are likely to be at risk. We've also seen that there are some technology around rapid diagnostic tests for HIV in the field and improve accuracy for testing by lay people. So I want to leave you in summary with a few recommendations that I think we need to consider as we think about designing and implementing youth-focused or digital tools for youth. Obviously, I think that's also our key learning, is that digital interventions, they should have a sound M&E or monitoring and evaluation system that inform the design and quality improvement based on their efficacy in contributing to young people's health outcomes. Secondly, content should be based on social and behavior change theory and evidence, and this should be scientifically accurate. Third is content should be developed with maximal engagement interactivity to ensure reinforcement of key messages and desired outcomes. Continuous moderation is required to ensure consistency in messaging, as well as ensuring the safety of the young users on digital platforms. The services that are well marketed, zero rated, free, etc., for users with constant updated content, they stand the highest likelihood of high uptake among young people. Digital health tools should be designed to provide bridges to in-person health services. I've spoken about this as well, because this is a particular area of concern that we have to be able to catch the people, the young people, and be able to offer them services in non-threatening, safe environments. Thank you so much. I think this is definitely my lesson.
Thank you, Dr. Mtshali. That was really stimulating and a brilliant setup for our second speaker, Dr. Homaira Hanif, who I hope is she online? Brilliant, who is online. Dr. Hanif is a behavioral researcher with extensive experience in designing and implementing interventions across multiple settings, working in research and program implementation. She's a faculty at the Eastern Virginia Medical School, and she works with CONRAD, a nonprofit biomedical R&D organization, research and development organization, where her work focuses on end-user research, evaluating product acceptability and supporting adherence behaviors. Dr. Hanif's presentation today is on VUCA Plus, a novel smartphone-based PrEP adherence support intervention for adolescent girls and young women. Thank you so much. And I'll give you a warning. You'll have until 1:30, 21 minutes, 20 minutes and a half. Over to you.
Thank you. Thank you for having me join today. I'm setting my timer so I don't go over. I realize I'm between everyone and their lunch break. So I will hopefully set up my presentation. So just to confirm, I'm sharing my slides, correct, and not on your end?
Thank you. Thank you, Linda Gale. We can see the slides. They're not on full slide yet, full presentation mode.
That good?
They're there now. Thank you.
And you see the presentation mode, not the...
Yes, just the
Okay.
presentation and full presentation
Okay,
mode.
great. Thank you so much. Thank you for giving me this opportunity to present on our smartphone app that we developed over many years and are currently testing with ETHF. So I'll just give a brief background on how we got to looking at developing an app. So we know that taking a daily pill is challenging for everyone, but especially young populations. And new technologies can provide improvements for individuals and as well as providers to monitor and support adherence. And so VUCA Plus is an intervention app developed to support medication adherence, persistence, and social support especially for adolescent girls and young women in South Africa. So previously, you've already had information on mHealth intervention, so I'll keep it brief. The reason why we're interested in it is that it's highly acceptable among young people, and it has shown to improve adherence across a number of studies, delivery modes, and populations. And mHealth tools can promote daily PrEP, particularly where women could be far from clinics and they might lack family or social support. So we're looking at using educational resources and tracking that can help optimize clinic visit times and help engage with participants outside of the clinic environment on their own schedule. And it also allows a chance for behavior to be tracked in real time with potential for tailoring of the content and providing individual support. So the project that the VUCA app that I'm presenting now is under Project Engage, which has a number of behavioral and clinical studies focused on adolescent girls and young women. And we're looking at adherence, acceptability. We have the digital health tool for interventions, as well as looking at point of care testing. And I'll focus today on VUCA plus the development process. And so this was worked through many years with different partners, and it was really tailored for African adolescent girls and young women, with a focus on the educational side, as well as practical and culturally appropriate content. The collaborators in the US that we worked with, they have previously developed other apps that have proven to show success, but it was among US MSM populations. So we did a lot of work in country with collaborators looking at customizing and enhancing the features. We added medication tracking. And I think what was also key was the ability to use it offline or when there's low connectivity in country. And then I'll mention a little bit about the V brand. This was a human-centered design project that CONRAD conducted with IDEO. And that project really is what the branding and the look and feel of the app is based on. So just to show you the different stages of the project. So we had done human-centered design research on the V brand, which is overall on PrEP, different choices, how to market it, what it should look and feel, lots of end user testing for that. And then we did specific formative research for the app development, and we did that in Kenya and South Africa. And then we created the app and did additional beta testing. So we had a lot of end user input and then further app refinement with the collaborators, looking at tech issues, looking at content, in various ways to make sure it's engaging. And then under Project Engage, we've been working with DTHF, where we did a 4-week pilot project, and then we refined the app further. And now we're in the midst of a 6-month randomized control trial. So this is the V brand, just to give you a look on we have a website on top if anyone wants to look at it. It tells you the research as well as the different products developed from this research. And this was co-designed with young women and looking at what do women want when it comes to, for my usual alarm. Sorry about that. So it's looking at what do women want when it comes to PrEP, and it's really moving beyond, don't get HIV into empowerment models, as well as demedicalizing PrEP. So people want something that looks more fun and isn't just thinking about the medical aspects of HIV prevention. The other end user research that we conducted, we used immersion experiences, in-depth interviews, focus groups, and we looked at current and previous PrEP users as well as PrEP naive participants. As I mentioned previously, we looked at what people said and added features in relation to that. So one thing about the app, while we have medication tracking, we also have other tracking, because such as tracking your finances or looking at other habits outside of just medication tracking, because that's what young people said that they were interested in looking at beyond just medicine. And then we did further revisions to look at really the functionality, so more on the tech side, since there's a lot of different kinds of phones. We do have an increase in the market of smartphones, and a lot of it could be on the lower end Chinese models, and sometimes there are tech issues in making sure everything works the same in country. And then for our pilot study with DTHF, we really assess women's experiences using the app, acceptability, and as well as the app content, And in our current 6-month trial with DTHF, we're looking at acceptability, usability. It's a clinical trial, so we're looking at dried blood spots to see objectively if people's adherence are improved in the arm with the app versus the arm that only has standard of care. And this is with 330 adolescent girls and young women. So here's just a brief overview of the app, just giving you some screenshots of what it looks like. We have motivational messaging in it. We have customized reminders. The incentives are within the app, so it's gamification features. We don't have any outside incentives. There are lots of resources on PrEP as well as other topics. And so I mentioned before we have tracking, so medication tracking and other habits, as well as appointment and refill. And then we also have side effects tracking. And for social support, we do have a chat forum and also the ability to send messages to the clinic nurse or have an ask the expert. For the home screen, one thing to point out is that, some people share phones, and also we want to make sure that this is a secure app. So you have to use a PIN in order to get into the app. And then the other thing is when you look at the home screen, it doesn't look like a medical app. So if someone looked over your shoulder or, you're trying to be discreet, it's not quite obvious when you're looking at this home screen that this is about PrEP or HIV. So that was an important feature of developing this app. Here, just to show you some of the screens for medication and habit tracking. When you first get into the app, it takes you through adding your medicine, connecting your habit with something else in your routine. So you get to choose what the medication you're tracking is. Then you can look at your habits and choose what you want to connect with. Like, I drink coffee in the morning. So then your reminder can also be customized with that habit. These are some of the tracking we currently have in here, which is PrEP, and any medication that can be birth control pills, sex life, so you can track your sexual activity if you choose, your mood, drug or alcohol use, as well as your finances. And this is the reminders that I was mentioning earlier. So there are already some in there that's connected to different strategies, but you can also customize and choose, what you want it to be connected with and what you want the message to be. So we didn't want, remember to take your medicine to be the pop-up reminder. So something simple like, what would be great with your coffee? Or some other message that would remind you to take your medicine. And then this is something that the person can change as well. Another feature is the calendar and analytics. So here, after you've tracked your information, you can come and look at your stats. So you can see it visually in a calendar view, as well as graphs showing you how much you've taken. The other thing is we want to promote people going into the app and tracking. So it doesn't matter if they tracked and they said, no, I didn't take my pill. The idea is that they tracked. And I think that's another thing. We don't want to say, oh, it's only promoting the positive behaviors, but just promoting tracking. And so then people can see, there's a layering of what you're tracking. You can see, how am I doing as far as taking my medicine, and maybe seeing how that's connected to their sexual activity or drug or alcohol use. So it's a chance for people to visualize, and hopefully they can see patterns themselves over time if they're tracking their behaviors. And then for the gamification features, we have this avatar where you get to choose what your avatar looks like. And a certain number of the elements, such as the hairstyle or the clothing, earrings, makeup, these things will have features that become unlocked as you use more of the app, as you read more resources or do activities. So that's a bit of the gamification feature if people are interested in using the avatar. There are also badges that pop up based on different activity levels. And that's another way to hopefully keep people engaged. So currently our app is not connected to, I mean, we're in the testing phase, but I think as the previous speaker said, it would be great for something like this to be connected to a program implementation where some of these features, these gamification incentives can be connected to something a service is providing so that they have something tangible. And then we have a lot of resources. This can be updated. I think that was a key point also mentioned earlier, making it interesting, keeping it current. So it's not necessarily a fixed content. It's something that you can release different information over time and refresh it and make it more engaging. So this has been really a key part of this this app that people have engaged with, and also having fun quizzes, kind of quizzes along the lines of what you have in magazines, making it, you know, be fun, be on other topics that aren't necessarily specifically health focused, but also learning through doing these quizzes. There is an Ask an Expert feature, so people can, in the study, put in a question here, and then people can see the responses. Of course, everyone has anonymous kind of username, so it won't be, so it is a private element to that. And then there is the chat forum, so we can prompt them with certain questions or polls or quizzes, but other people can also start their own topics. So that's just an overview of the app. I'm just checking my time. Of the app, and I just wanted to give you a little bit of the pilot data. So from 4 weeks of use.
Homaira, you have
Yes.
about 7 minutes. Just, I think you're wondering how long.
Yeah, I just
you-
looked at my clock. Thank you. So
Yeah, brilliant.
I am near the end, so thank you. So for the pilot, about a third of them consistently tracked PrEP use and reported high medication adherence. And the participants use the app on average about 5.5 times a week. And the most utilized feature was the tracking PrEP adherence. The other thing that people really liked were the activities. So these are kind of like the quizzes, knowledge quizzes, as well as reading articles. And then less was use of the avatar page. From some of the qualitative interviews, I just wanted to share what participants said about the medication and behavioral trackers. And I'm not going to read all of this, but people did enjoy tracking their medication. This person said, it influenced my decisions because every time I took a look at the calendar, I would actually see that I was becoming more responsible, and meaning the app has a lot of influence because it helps you take your medication, track different habits, because without the app, who would have known? So, I mean, I personally, you know, track certain things, but I think also some of it might be, what do young people in South Africa want to track? Do people like tracking fitness, things like that? I don't know how much those features are getting used on phones, but this is an opportunity to use it in the healthcare setting. And then as far as the educational features, they were very highly utilized and positively evaluated. So this participant says, those multi-choice questions kept me busy. I like that it teaches you by giving you correct information. For example, if you're doing an activity, then you answer your questions incorrect, it will instantly correct and learn as well. So it was good. And so some people were really into it. Like this other participants completed about 50 of them and said they learned a lot from those activities. So I think it was just, you know, we can provide information and try to do it in a fun way for youth to absorb some of that. So, so currently we have a fully enrolled trial, and we expect to have results on acceptability and adherence in the next year. So we're excited to see about that. And then we are looking at this in a randomized control trial setting, but I really think for the next steps, it would be great to implement this with program implementers where it's connected to other services and it's part of an adherence package. I think would be great opportunities to customize different features and content outside of this testing setting. And we're also developing a WhatsApp intervention. So using some of the features and content of VUCA and using that within the WhatsApp platform, given that it is very popular in a lot of settings. It wouldn't be an app, but another digital health intervention. All right, so I just wanted to acknowledge all of the funders and different partners involved throughout this process. So there are a lot of different people working on this from the tech side to on the ground implementation. All right, thank you.
Thank you very much. And it would be great to have, brilliant. We have you on a big screen in the middle of our meeting room. Dr. Mtshali, I'm wondering if, sorry, maybe in the panel. So everyone will take about 15 minutes. So we'll cut the Q&A a bit shorter, but we have already 2 questions for Dr. Mtshali as she's making her way to the front. Maybe I could start with you, Homaira, if I can, to speak a little bit about, it's great to see all the successes. I'm going to also ask this of Dr. Mtshali and Dr. Hanif, both of you. I'm going to go with first names from now on. Could we talk about things that you've learned that were about what didn't work? Maybe one example, because we learn a lot by failing, which is great, that surprised you. So maybe Homaira, if you could start, and then Ntombifikile, I'm not sure if you have a mic, but you can go next. Over.
Yeah, so we are still in the testing phase. So I would say I'm sure we'll learn a lot more in the next year as we have data come in. But some of the things that I have wondered maybe about how people use technology potentially in South Africa that could be different from the US populations, or what youth find engaging. I think I was surprised that there was less engagement with like the avatar page, which I thought, if this is something people can use offline, that they might be interested in changing their avatar or playing around with that. And then I think the chat forum, so using those kinds of more public ways of communicating hasn't been as successful. So I think in the US, maybe that is more common for people to go in sort of those sorts of online forums. So I think there's, for this population so far that we've worked with, it hasn't been as successful. So I think it's important to really kind of understand how people use technology and to see then what features might be successful.
Thank you. That's great. Ntombifikile.
Okay, thank you. I think so first lesson that we definitely learned, and this has shaped the way that we've approached it, was certainly around data cost in South Africa, because that's a unique challenge, particularly in the populations we serve. Gauteng has 2 metros, at least it's not as bad, but we still know that that target population, they would not have access to data. So designing our tools and our platforms to be data-free as much as possible. The chatbot is not data-free, but it uses very low data in terms of that. So that was very important in us shaping how this needs to look like. I think in one of the things that I mentioned at the last slide was really having clear, so as we start the campaign, being very clear in terms of the M&E pieces, what it is that we're tracking, what is it that we're expecting, et cetera, et cetera. I think those are the 2 key points. I don't know if Stephen, you want to add anything? I'm putting you on the spot.
Thank you. One of the other issues that I think we've talked about is that for many stigmatized health services, young people want anonymity. So the use of WhatsApp, we can create our own digital platforms and sometimes give them anonymity, but when we're trying to also link them to services, sometimes they give us information that would identify them. So to have tools that both give anonymity and don't, I think is also important. And as Ntombifikile said earlier, with services like GBV, we'll do screening we'll ask questions, even HIV sexual risk, they'll tell us one thing, but then if they have an opportunity to anonymously ask questions, I think we get more truthful answers, and it gives opportunities to provide a bridge to services. So that, I think that's the other learning on our side.
And that's particularly relevant to the age group. It's true for all people. Thank you, Stephen, nice to see you over there. The two next questions, I think one has been answered in the chat, but it's just maybe great for everyone here to know. The question was for the Shout It Now team, where the Chomi app can be accessed on Google Play Store, and it is there. I think there is a link in the chat, but if anyone struggles to find it, you can see the two colleagues here who can help you locate it. And I've tried the WhatsApp chatbot and Chomi, and it's great. The second question is also for Ntombifikile. Thank you for the amazing presentation. Dr. Lynn Hendricks wants to know if you're open to collaborating on other types of interventions being used on the same app platforms that you are currently running.
Absolutely.
Yes,
okay, no, it's fine. So on another thing that we've been very purposeful about, especially when we're designing our apps in the South African context, as you see, there's around 150 apps, digital tools, and platforms that exist. And ours is really, how do we make sure that some of those, as we scale, how do we make sure that they are integrating as much as possible to existing systems? So we've been very deliberate about designing apps that can integrate. Already in terms of our Chomi chatbot, for example, we've been very clear that we don't only want to use it in our geographies, etc., because we think it can be a value add. So we're really open to making sure that issues and plugging and connecting the youth to services that they need, whether it can be mental health support, it can be substance abuse, it can be PrEP in other geographies, etc., etc. That's how we've designed it, or with that purpose in mind. So definitely happy to collaborate. Thanks.
Lynn is very excited on the chat, so thank you for that positive answer and being open to collaboration. I don't know if there's any questions from the audience in person. There will be, is everyone too hungry to think? That is a thing.
Yeah.
I see one microphone in front. Please go ahead.
Thank you. Not a question on my side. I just would like to really appreciate the amazing research that has been done, really inspiring, very informative as well. Recently, I was working in an insurance industry. I was in the life and health space. And the problem that we had, I was doing some research in East and West African markets. And as part of my research, I had discovered that infectious diseases are the leading causes of death in these regions, and they're driven by HIV. So and this is no secret that with the rise of diseases comes the rise of premiums in the insurance space. So now in pricing and making sure that the company that I was with was tailoring products that were to cater to the needs of these communities, they sort of developed a sustainability initiative that would then develop something that is similar to what Dr. Ntombifikile was talking about. I think it's iMarket, something similar to Discovery Health Vitality, but unfortunately that one only caters for people who are like up there in the economic pie. So I think collaborating with insurances, life and health insurances in particular, would really be helpful in making sure that these great innovatives reach the larger populations, especially the underserved communities. Maybe in future, they were actually looking for collaborations. They just didn't know how to do it.
I see that. Please do engage with it. That's great.
No, definitely. It's just to acknowledge that that's very important because we exist in these communities. It's very important to scope and map out. What we've been very deliberate about is not duplicating. So already I'm thinking about the VUCA app that has been shared about this afternoon, I'm thinking, how do we make sure that we can not continue in our own trajectory when there's stuff we can learn from each other? So definitely key lessons, collaborating, figuring out who are the partners and how we can support. There's a big pillar around the DREAMS program of economic strengthening, and it really is also around how do we link young people to opportunities. So definitely there could be conversations and synergies we could explore there. Thank you.
Thank you. Homaira, would you like to speak to that point, or shall I move to the next question?
Next question.
Brilliant. And that's actually for you. So I'm glad you're ready. But I think this could actually apply to the Shout It Now team as well. So maybe we'll give you a chance after that. How many iterations did you go through to get this right, especially in the design phase, which the person who sent the question assumed it was a co-design phase? Over.
Yeah, so I was actually just answering to that online. So I think there a lot of, I mentioned the V brand, which was before we created the app, but that informed the app, and which had a lot of end user engagement to get that. But once we, before we did the app, we had the formative research, and that was done in Kenya and South Africa. And I think one of the comments I think someone made about data, it's interesting because in Kenya, it's very different. And people seem to use phones differently because data isn't as expensive as it is in South Africa. So I think that does inform how people use apps and interact with different interventions. So we did that formative research, we developed the app, and then we did more use in country to make sure, because there are a lot of different issues, tech issues even that can come up. Then we did the beta testing. So it was giving the app for 2 weeks to different potential end users to use it, and then getting further feedback from them and figuring out what potential tech issues there can be. And then we did the 1 month pilot study, and now we're in the 6 month study. So in the beginning, there was a bit of a co-design process, but since the development, it's been more testing using that feedback and a lot of revisions as little things keep coming up about during implementation.
So not a fixed number of versions, but a lot of iterative
change.
change
And a lot
learning.
of just things that keep coming up, and you have to update technology, and things are constantly changing in the different phones. So there's a lot. You have to have a dedicated tech team that can work on it.
Mm. And you've paused it when you test it during these periods, presumably, and then you collect data that you'll change it again, like during pilot.
Yeah, so I mean, ours is not currently available for anyone to download, so it's still in that testing phase. So you have to be part of the study, or for us to give you access to it. But yeah, once it gets updated, whoever has the old version, it no longer works.
Thank you. Would you like to speak to that, Ntombifikile?
It's just to echo what you've said, because we are on version 1 of the iShout app. However, we do acknowledge that it will be an iterative process. So, and also as we get user feedback, as we get more content, we are able to adapt it accordingly. Thanks.
Thank you. There's 2 hands in the audience. Red jacket at the end and pink shirt, striped shirt.
Good afternoon, everybody. So this is just a question for Dr. Ntombifikile. Through your social media campaigns with role models, how are you able to measure impact in terms of the number of new participants that come in your mobile clinics?
I have to keep testing this mic. So what we do in terms of those particular campaigns, we try and link them to, if they ask them how they came to know about our service. So most of this is self-reported. And that's also why I was talking about the M&E and processes, et cetera, and how we're going to be able to quantify that. We know also just in terms of Facebook and other social media as well, we know the ones that we can track from that, but we know that there are others who come not through that particular app. So the number is larger, but we're not able to track it always, accurately, but we know that it does have an impact. Thank you.
Thank you. There is a question here.
I have a general question regarding like the future options that are going to be available. So like earlier you spoke about AI, and as a researcher, I always worry about open data sourcing and how our information is contaminated with things that aren't true. Especially within the health space, we see that everybody has an opinion. And that opinion is often drawn into AI databases to give adolescents an answer about their health outcomes. So, I mean, as you were suggesting that AI is an option, like, are the ideas that are currently existing to have closed or boarded AI options, or would they also be open AI content? And then how would researchers actually feed into that space?
I think this is a complex question. And I guess as a researcher who's asked it, it means it's a very good question for you especially. I think when we talk about AI, it is an emerging field, so to speak. And we know that in the same way that social media, other platforms can be used, can have harms, and also if it's not filtered, et cetera, we need to be able to create platforms that we know that information is credible, et cetera. I don't have a straight answer in terms of how we go about that. But I know it just means from the user endpoint, we need to have, so like those search engine optimization. So if they put in keywords, that's the credible sources are gonna come. I know particularly for COVID-19, they had to do that because of the lot of misinformation. So if you Google something, you only get NIH or NICD, et cetera. So those are some of the things that are actually possible to do, but means it needs to be well thought out. I think also from the end users as well, there's a concept called prompt engineering. I don't know if you've heard about it, particularly for AI. So you actually give the tool or you give the search engine more information. So I am this person. This is the information that I need. These ask me questions around how you can give me a better response. So it's basically how we also educate people around that. Thanks.
Thank you. Homaira, would you like to pitch in?
Yeah, I mean, we don't have experience, but there's, again, a lot of interest. And I think it is going to be key thinking about how we can incorporate AI in a way that we can also manage it and make sure we're giving the correct information with our populations. I do, and that's something we will look also into our WhatsApp intervention. So can we incorporate it in a way that we can make sure we monitor it? And I think it's an exciting area. And then I agree with Lauren, there are potential pitfalls and areas we should be aware of. So, but I think with anything, there are always going to be pros and cons. So if as much as we can be aware in advance to try to mitigate those potential negative consequences.
Thank you both. I've been told that we are run out of time. So colleague in the center, please find one of our speakers at lunchtime. You can hopefully ask the question if it's for Shout It Now. There's also 2 comments in the chat. I think one we've actually addressed because we discussed some of the issues around the future and how do we keep generating and do it in a safe way. So I'm sure there's lots of interesting conversations that can continue. Thank you, Homaira, for joining online, and Ntombifikile and Stephen for the great work that you are all three doing. And enjoy lunch, everyone. Is this the last session? Can I hand it over to Melissa? Thank you so much.
Okay, thanks very much. That was great. All right, so we are actually finished for the day, and I know that everyone must be really hungry by now, and the kitchen's waiting for us as well. So I'm not going to keep you for much longer, but I can't let this end without saying a few thank yous. Also, just quickly before I do that, just some about the parking tickets. A few people have asked.